Welcome in, everyone. Welcome, welcome.
Good morning, all. Welcome in. We are in the fourth and final day of this series on CQI plans and how to utilize them and to make improvements on the class standards. We have a short presentation for you today that Matt's going to lead, and then most of the time for this meeting is going to be for you to ask questions and have discussion. So we really encourage you to think of questions that you want to ask and information that you want to leave this meeting with before we head out of here at 10 o'clock. I'm going to go ahead and hand it over to Matt. Matt has a short presentation, and then we'll get into the Q&A for you.
Yeah, welcome, good souls. I'm seeing some familiar faces. It's been lovely to do these presentations with you. So we just have a quick recap slides today. I'm going to go ahead and pull those up for us. And then, like Zane said, we have mostly, let me get rid of this. How do I move this? Okay. But yeah, so we'll go ahead and get started here. So this is our recapping questions. My name's Matt Spija. You guys have seen me before. So just really quickly going over continuous and ongoing efforts. Again, we're looking at efficiency of data collection. It should not be a hard process, but once you get into it, it becomes like riding a bike. Practice makes perfect with our efficiencies. Get into a time period. Friendly reminder, we do run Ames reports every 16th of the month. They are due from you on the 15th of every month. Yeah, welcome in. Yeah, any issues, please message Zane. He'll help you out. He's been awesome this whole time. Um, but yeah, so we run Ames every 16th of the month. They are due from you on the 15th. Again, if you need any help, please do not hesitate to reach out to us. We are here to help you. And the effectiveness of our data really does help us advocate for you as well. Not only does it improve your organization and seeing your outcomes, seeing your measurables, but it really does help us to advocate for you as well. When the legislation asks, how is this money being used? When our leadership asks, it really does help us advocate for you. And it helps us measure your performance as well as you measuring your performance, seeing how you're impacting your communities, because we know that we all want the best for Kansas here, and being able to accurately measure our performance is such a huge thing. And then accountability, the more you can show us, the better we all feel about it, not only from an organizational level from yours, but going up to us. We know that we need to see correct, accurate, accountable data in our outcome measures. But just a friendly reminder, CQI is a continuous and ongoing effort. It's not a one and done effect. We do want to see measurable improvements. And you saw this graphic from Jane the other day. I know it's another big graphic, so I wanted to give it to you guys again. And just walking through it, projection of the increase in people served. The better that we do, we know that health outcomes dramatically increase not only retention in our communities, but the want to move into them. People want to know that they have safe, effective resources when they move into them, and target populations, knowing that we're serving all peoples that walk through our doors and create the roads back to us. All roads lead to Rome, but they had to start from Rome to bring people back in. So when you're serving down those roads and those lanes to get people through your doors, it's much more effective. Seeing where you can directly address issues inside of your community, like overdose, veteran access, whatever that may be, service and gaps and barriers to access. We always want to be increasing the number of people that we're serving and increased access. And your clinic location and hours might vary, and they probably will. If you know that, hey, Friday nights, everybody's out at the local football game. I know that's how it is here in Alma. You might be able to close early, but hey, the next day people need access on Saturdays. So, adjust your plans as needed. A question that did come up, not through these, but one of our centers did reach out and ask about this. So on the staffing plan, it might not make sense for you to have an entire one person dedicated to something, but you do need to be able to have a point of contact for those services. So, split the responsibilities as you need to. You don't have to have one specific person dedicated to everything, but you should have a point of contact for all services. Constantly using evidence-based practices. We know this is huge. The SAMHSA webinars, especially on YouTube, they've been very good about posting them. You can also find them through the sites that Jane posted. And again, you will have access to all of these slides, and we'll send those out to you. Um, And then we did talk a little bit about the DCO models, but I wanted to dive a little bit further into it since Jane focused really on the being data driven. I did want to talk a little bit about DCOs. This is not only a community bridge, but your directed care organizations can really fill gaps that you just don't either have the staffing for or the training for, or maybe they're just doing it really efficiently and you like their model. Reach out to them, make those connections, and figure out how you guys can work together. The more people working in your community together towards that one goal, the better it's going to be. And then current outcome data, we've talked a lot about that, but I just wanted to show you this graphic again. And this is the Plan, Do, Study, Act. Plan, Study, Act. Yeah, Plan, Do, Study, Act. Suffering succotash. It's early in the morning. My cup of coffee has not kicked in yet, if you couldn't tell. Another way of thinking of this is the ODA loop, and this would be more applicable to crisis or immediate actionables. These are your long-term plans. Plan, Do, Study, Act is a long-term one. The ODA loop is a more short-term one. ODA stands for Observe, Decide, Act. And remember your SMART goals: specific, measurable, attainable, relevant, and time bound. As my father would say, things without deadlines are often played with. So when you're setting these goals, put a deadline on it. And if it needs to get moved, it does, but always shoot for having those done at an accurate time. And then again, going back to the data quality, again, you've seen these slides before. This is just a quick recap for us. So the utility of it: relevance, accessibility, timeliness, punctuality, and granularity. The better the data is, especially on granularity, the further we can break that down. We can see, instead of just quarter to quarter or half year to half year or even year to year, the better your data is, the more granularly you can break that out, and we can start seeing excuse me, outcome measures a lot better. And this can be, from month to month, and you can really see it a lot in target populations and our outcome measures. Um, then the objectivity, accuracy, and reliability, and also coherence. Um, Data should not just be numbers that come out of a big spreadsheet. Coherence means we can look at these and understand what the data is trying to show us. And I know a lot of the time, especially with our aims, you'll see numerators, denominators, null and none voids, and it can be complicated. But again, if you ever need any help, please just reach out to us. We work for the state, which means we work for you. So coherence means you should be able to be looking at them pretty easily and understand what they're trying to show you. And then integrity, both scientifically and credibility wise. Um, Again, this just goes back to allowing us to advocate for you. The more credible our information is, the stronger we can plant our flag and advocate for you, advocate for these services to remain in Kansas and the funding levels to remain in Kansas. Computer and physical security as well. Um, Touching briefly, just because we haven't yet, friendly reminder that after the end of December, we will be moving to WCAG 2.0, which is Web Accessibility and Compatibility Guidelines. It's a big acronym for a pretty easy thing. Make sure your sites have screen readers, captions if needed, ASL if needed, and we did talk a lot about translation services. So just very quickly, you guys know what the CCBHCs do. Um, but again, these are just recap slides. And again, the criteria here: the CCBHC has the capacity to collect, report, track, and encounter quality and data, including but not limited to characteristics, staffing, access to services, use, screening, prevention and treatment, coordination of care, primary processes of care, costs, and outcomes of people receiving services. And this can be everything from liaisons to tracking people, and this just goes back to data and requirements of it. Again, if you need any help with these, please reach out. Also, remember, Kansas Train has quite a few free resources for trainings, along with the KDAD's website for license abilities. Like I said, a pretty quick presentation, just a quick recap of what we've been going over today, these last couple of days. Yeah, 10 minutes, perfect. But we mainly wanted this time to be questions, concerns, sharing success stories. Brag about yourself. We would love to hear some success stories because it'll give people other indicators on where they might want to be. Does anybody have any pressing questions that they want to get off before we start talking about our success stories and what's really worked well? Don't everybody speak at once. Okay, I'm going to start calling on some names. We're going to talk about some success stories. I want to hear what your centers have done really well, because a lot of the times it feels like, there's a new thing every day. There's a new requirement every day. We're behind on this. Let's talk about some success stories. Let's use this as a morale boost. I'm gonna call on somebody here. Let's go with Michelle Otten. I see you have a picture and you're kind of high up on my list. If you want to come off camera and mute, or just mute if you're not
Hi
comfortable coming
there.
off camera. Hi, how are you?
I'm all right. How are you?
We're doing fantastic. I just wanted to hear of a recent success story. Like, if there's no questions, let's use this time to boost morale, share some stuff that's worked, and hopefully people can take, what worked for you and kind of implement that for them.
Okay. And well, so I'm in QI. I'm not front facing with clients. So, I mean, I could maybe just share like an experience of things that I've seen that are, I don't, might relate.
Yeah, or challenges you faced, whatever you. I just want a quick, 2 minutes of a success or a challenge you faced, because I just want this session to really spur discussion. That's what this one's designed to be.
Well, I don't, you can let me know if you think this is relatable or not, but we do a process called RCAs, which is root cause analysis, like when there's an event that happens, which could be like a suicide attempt or medication error or things like that. Um, and I've seen some positive change with that in seeing that the staff are like completing the steps that are necessary, like for policy and like organizational standards, like getting um risk, like doing things that need to be done, like risk assessments and safety plans. And so I've seen since I've started this position, an increase in that, I would say.
Okay. Well,
Is
very good.
that
Yeah, no,
close
excellent.
enough?
Yeah, no, root cause analysis is a great thing to be talking about. Like knowing the tools behind it, especially medication management. Are you guys utilizing any technology to help with that? Like, I know there's automatic pill organizers, reminder charts, especially for people that have short-term or long-term memory loss.
We do discuss prevention a little bit in the RCAs that is really more up to the team,
Okay.
um, the treatment team itself. But definitely like the floor is open during the RCAs for that kind of discussion. But yeah, those things have been talked about and like using bubble packs, you know, being sure there's no guns in the home or having a plan in place.
Absolutely. Now, that's a great example of just something behind the scenes that, a way to apply statistics to something that maybe people aren't thinking about. Yeah, go ahead, Steve Denny.
I did think of a question. Thanks for putting this on, guys. It's been really useful. We get good to reconnect with Jane. Hear her for a little bit. My question is, you mentioned early aims, and of course we have our aims measures. We have our measures we submit for CCBHC, the data warehouse, and if SUD services, we have our CASERs or Well Sky data, and they're all kind of three different data sets that are kind of managed differently that have a lot of overlapping data. And I know there's talk of eventually moving AIMS into data warehouse. My question, I guess, a couple things about that. That there are a couple of areas where we're collecting the same information, but they kind of mean different things. When you think about initial contact and first contact, those both have ISERV implications on the CCBHC side, and they have some access implication on the AIM side. And with that, there's also some things like in AIM, like for our SBMI, SMI populations, there's things like homeless information and there's information about employment. And we're also tracking that in other places. So I guess my question is, what are your thoughts about how we can maybe streamline some of these data points in the future so that we're not potentially collecting three separate data sets and maybe finding a way to bring those together. If I understand it, there's some talk about merging some of the block grants at the federal level for SUD and mental health. So I'm just curious what your guys' thoughts are on what that could look like down the road.
Yeah, so we do hope for definitely increased efficiency. The data warehouse should be able to increase a lot of ease of access. A little behind the scenes, Ames is written in a proprietary programming language, so it does create its own kind of glitches. Um, where the data warehouse is written, what's the name of the company, Heather? I know the language they wrote it in, but who's writing it?
It's NetSmart is
Yeah,
doing
NetSmart. Thank
yep,
you.
yep.
I had Netscape in my mind. I'm like, that's not quite right. But they're using more of a universal language, so you shouldn't have, frankly, the uploading issues that you're currently having with Ames. That's written out of their proprietary language. Um, but yeah, we'll have to see where it's going federally, because honestly, who knows how the winds are going to go through there. But it should remove a lot of the, I don't want to say duplicative because they're used differently and they're granularly different, but it should increase your ease of uploading at least.
Thank you. And just this is just one of those little things that bugs me, but I think probably other people deal with it. So when we report average household income on Ames, it says in the manual, I believe, that if they don't have it or if it's not available, you just put 88888. I don't know if you're aware of that.
Mhm.
The problem with
Yeah.
that is that when you're running data and trying to get meaningful average household income data, that all shows up as $88,888. So you have to filter and like, if we're trying to use it in other places other than Ames, it makes the data look really strange. So that's an example, maybe some antiquated methodology there that we could probably
Yeah,
improve in the
and
future.
and that will be removed coming out of the data warehouse. That 8888, where that comes from is it's a filter, but it's also a null code.
Right.
So for export, it's a null code,
Right.
but that's why that number exists.
Yeah,
Kind of
and
like
I
if you've
understand
seen,
the history of it. It's one of those things.
yeah,
It's like, oh, that kind of messes with their data a little bit. So anyway, that was my question. Thank you.
yeah, and when you do an export, you can do filter exclude. So you can tell it, you'll do it bracket, quotation mark, that number, quotation mark, end bracket. That's an exclude code. So you can filter it that way instead of having to go find the records, if that's helpful. Great questions. Yeah, Ames is complicated, and that manual is kind of written in quasi-code language, so definitely ask away on those. But the data warehouse should make life a lot easier. We're hoping. Yeah, I'm going to call on people for success stories if we don't have questions. I'll give you guys a little bit of time back, but not this much time. I'm going to keep you here for that. All right, I'm gonna call on somebody. Let's see who has a photo. Let's go with Marissa Long. If you don't have to come off, you don't have to come on camera if you don't want to, but if you want to unmute and share a recent success story from your center.
You're trying to get, there we go. There we are. Okay. We do utilize Plan, Do, Study, Act here. I think systemically that's a hard sell for people because it feels like another piece of paper or another spreadsheet. So we have quite a few success stories, but one of them recently was more of an ODA, I think is like the acronym you used, but we discovered in our intake bundle that some things just didn't really make sense. And so we took a poll from a few of the clinicians, we moved some things around. We added the PHQ-9 to the progress notes. So it's optional that they do it, but it's in your face like, hey, we need to get these as often until they're in remission. So a way that we can, meet that quality measures of the depression stuff. So we've been doing that, and that there were some glitches with our EHR. I feel like that's always the biggest challenge, but usually it's a pretty positive thing. People find it way more accessible because out of sight, out of mind, right? Like, oh, I have to go and do another assessment. If it's right there, it's like, oh, I could do this really quick. So that's been a success so far. A long-term one was we had what we call a PAO, patient assistance options, and we had a really bulky old process when I got here. And the person that was in charge of it's like, this is just a pain. We're emailing all these people to be like, do you approve these free sessions? You know, so we're risking PHI kind of getting to the wrong people within the agency, but like there didn't need to be that many people involved is basically what I'm saying. We didn't need to have 9 team members approve, you know, 3 free sessions of case management. We needed the adult case management person and someone and like 2 other people to approve it. So we found out we could do it electronically in our EMR, and we got rid of that whole big old email chain, which, you know, led to more efficiency in our inboxes and cut down the risk on people seeing names they didn't need to see. And so that was more of a long-term project, but that's just going really smooth now too.
So that's fantastic news.
Yeah.
Yeah, especially transitioning from, I mean, old servers or even paper and translating those into a really good digital process is hours of work saved.
We also did, we bought a platform like, you know, like Smart Sheets, Monday, like those project management platforms. And we created our own internal incident reporting system. So it's HIPAA compliant and we no longer use paper for that too.
Oh, wonderful.
That's great.
Yeah. And so I have all these, you know, I have all this data. It gets the people it needs to get to. It notifies the people that need to know. It color codes things with, I had a risk stratification. So I'm getting people to try and think about, even at the ground level, anyone from a case manager to a peer attendant, if they're doing incident report, they're picking, you know, the risk, so the matrix, it populates the color as red, orange, green, or yellow in my spreadsheet. So I kind of go through and make sure I'm agreeing or not with it, and then I'll color code it. But what EMR do we use? It's CareLogic, and it's not my favorite. Let's put it that way.
Yeah, you read my mind. I was just about to say if you could say that just a little bit slower on that. But
Yeah,
you said
it's CareLogic.
CareLogic.
Qualifax is the
Okay, qualify. Okay.
Yep.
Yeah, and what was the timeline on implementing that for you guys? Like, about how long did it take to go from we should do this to it's working great?
So for the incident reporting or the PAO?
Either one, both.
The PAO I started talking to the person about it, and the person that was originally kind of doing all of the weird paperwork stuff that didn't really need to happen anymore. They are very efficient and systems minded too. They use the Smart Sheets platform that I do to create crisis data stuff. So anyway, they, I think from the time it's May, June, maybe like 5 months.
Oh, that's pretty quick.
People really like their paper. So it's like with any organizational transformational change, it's really hard to kind of like, oh, there's a better way. Let me just take that paper that could be like blown into the wind or left somewhere it shouldn't, or just get lost in general, and it's just not useful. So there was a little bit of resistance, but once it got going, it was awesome. And then for the other project, the PHQ-9 stuff, we did like basically the OTA model. It was like, let's just change it. Like we pulled 5 people. We'll say we welcome your feedback. And that happened within like 2 or 3 weeks. And then we had to make sure we communicated it out appropriately. That's the big thing too, I think, is communicating change is hard sometimes, but yeah.
No, that's fantastic news, especially with how quick both of those were implemented. Like, bravo, truly.
Oh, thank you. I love data. I'm a big data nerd.
Yeah, very much a numbers type person too. So I love hearing the efficiencies on that. And I'm sure it just made life so much easier not having to keep track of physical files.
The incident reporting system is night and day difference because I was tabulating these Word document, like think of all the categories everybody has for everything, and then like keying those into Excel. And it just was not. This is just like an icon on the desktop. It makes reporting easier for everyone. They're not having to go find a form and then handwrite it and or type it in, and then the boxes get all messed up. You know how it goes. Like it's just a pain.
Yeah.
It's night and day revolutionary for my time management.
Yeah.
The more time back in our day, the better we can do our in general, sir. That's an excellent example of a success story. Thank you, Ms. Long.
Yeah.
That's exactly the type of stuff I want to hear about. Because, and if you wouldn't mind dropping that name in the chat if other people wanted to utilize it.
Oh, no problem. I wanted to add one more thing. I'm trying to use Smart Sheets is the name of the project management. And I built the program. I just like trial and error. But there is definitely some learning curves, but we're going to try and do the Plan Do Study Act as an icon on people's desktop as well, so that anybody, if they have an idea for improvement, can, we encourage people like, hey, go to your supervisor if you have an idea for improvement. Like, that makes sense, right? Like, within your team, like, figure out what the left and right limits are. But we want to get people to tell us their ideas and know that we're actually listening and be like, we got this, like, this is cool. Or I don't know, people want to feel heard, and they usually know better than we do because they're doing the work, not me. So
Yeah. And I love to hear it's, ground up, what's actually happening on the ground. Let's implement that on a leadership level. I love that mentality of it, not top down, bottom up. And I'm sure that's helped with retention as well, because we know staff turnover is definitely a challenge.
thank you. Yeah, we have a lot of smart people, and they do a lot of really good work, and they need to be heard.
That is exactly what I want to hear. And I would like somebody else to tell me a story about that.
I'll share something. It's more on the service level than, I mean, we've done a lot of stuff with data, and our data analyst has built us some really great dashboards that we use to monitor our quality measures and things like that. But on the service level, last year they opened a new behavioral school in our county. And just noticing how many crisis contacts we were having at the school. And of course, we have a school-based therapist in that district, but they go to all of the schools in that district, the elementary, the middle school, the high school, plus case manager and stuff. So when it came time to do our new cost study and stuff, we were able to put in there for a therapist and a case manager to be specific and based at that elementary school or at the school for kids with the behavior disorders and things like that. So that started this school year. So far we've already seen a decrease in the amount of time our crisis staff is having to spend there, just having that therapist on site. And it helps that that therapist is a male, and he has been able to form some relationships with, the boys in the school that are typically are struggling with behavior and things like that. So we've seen a really positive outcome so far from that, for adding those staff specifically to that school.
Well, fantastic. And are you seeing like a decrease in intervention rate too, since you have an on-site person?
Yes, and he's also able, he's on site, and so if a kid is starting to get escalated, the staff can contact him. He can work with that kid to, help de-escalate the situation, so it doesn't rise to the level of crisis. It doesn't rise to the level of law enforcement having to be there and stuff like that. So that has been a really positive change, so that our crisis staff aren't constantly responding to the one school all of the time.
Well, fantastic. Yeah, and that's why we talked about staffing plans, and you addressed a direct need and you saw a better outcome because of it. So, I mean, exactly what we want to see. So yeah, does anybody else want to come on? I'm going to call on at least one more person. I'm going to call on somebody. We can volunteer. All right. Let's see. Who haven't I not heard from much? Again, you don't have to come on camera if you don't want to. But how about Ann? I might say this last name wrong. Rudder. Please correct me. With a last name like Spezia, I want to get last names right.
Good morning. Yes, it is Reuter. So, I am fairly new here. I began here in March, and I was actually invited to join in with these webinars, or Zoom meetings, to learn more. So I really don't have anything to share. I have been on CQI committees in other places where I have been employed, and so I'm familiar with the aspect of it all. But this has been a very good take on how to do it and how to keep it. It's a live thing that keeps growing and keeps moving, And so but I don't have anything to share for you.
Well, I hope your onboarding process into your new role went well.
Yes, it did. It did. So it did.
Well, great. We love hearing new people getting involved in making lives better.
Hmm.
But thank you for coming on.
Yes, thanks for inviting me.
Absolutely. Um, well, good souls, does anybody have any more questions? And as always, kdads.bhs.ta@ks.gov. We are always available. At least one of us will be. But does anybody have any more questions? We might be able to give some time back. We must have done just such a great job, Heather, Jane, and Melissa. We just must have done such a great job with our presentations. We've got everybody locked in on CQIs and class standards. Yeah, absolutely, Leslie. Thank you guys for being here. And thank you, Heather. I was just about to ask if you could do that. She read my mind, y'all. But good souls, I do appreciate you all attending here. The slides will be made available. The recordings will be embedded on KDAD's site to be able to be watched. Other than that, I hope you have a phenomenal Thursday. And again, if you guys want to reach out individually, we are more than happy to answer questions. Zane, is there anything you wanted to conclude with, or Heather?
Just thanks for all your time and dedication, not just to this training, but to really improving the CCBHC model at your center.
Yep. Thanks, everybody. Have a good afternoon.
Bye, guys.